And thank you for joining United States of Care for this virtual webinar on how we talk about a healthcare approach that prioritizes quality over quantity. My name is Kristen Wakilius, Chief Program Officer at United States of Care. And I'll be joined for this webinar by Dr. Venice Haynes, our Director of Research and Community Engagement. This briefing will be approximately 25 minutes and will be recorded and available for circulation. With that, we are eager to dive into our latest findings. United States of Care is a nonpartisan nonprofit organization dedicating to building a fairer healthcare system that is affordable, accessible, understandable, and dependable. We ground our work in listening to people and what they want in the healthcare system and work to advance changes at the state and federal level. Shortly after our founding 5 years ago, we began a multi-year foundational listening effort, engaging with people across the country and across demographics about their experiences in the healthcare system and what they want. We found many commonalities that united people across race, geography, and political party, and created a roadmap of 12 smart policy solutions that ladder up into 4 overarching goals that reflect what people want out of healthcare. Many of the complaints that people shared about the system are around what they lack. They lack coordination between providers. People feel like they have a different provider for each part of their body. Many of the complaints that we heard, we knew stemmed from the fragmentation of a fee-for-service system. And while people never actually used words like fee-for-service or value-based care, we know that accomplishing many of the things that people want, a system that is understandable and is easily navigated, a system where people can seek care in their communities, requires moving away from fee-for-service and towards new models that encourage coordination and quality. My colleague, Dr. Venice Haynes, will share more about the work to deeply understand people's attitudes about these changes.
Thanks, Kristen. So throughout our last 3 years of listening to what people want from the healthcare system and the sentiments that led us to our United Solutions for Care that Kristen just walked us through, we increasingly heard people talking about the greed associated with the system and a call for better care that focused on the whole person, where a doctor would take their time and listen, and where their doctors coordinated with other specialists they see, and not having to repeat their patient history every time they saw someone. Now, if you think about it, what does that actually sound like they're describing? So given the broad consensus on the kind of healthcare people want, we thought about 3 essential things. 1, how can we leverage what people know and want and connect it back to the virtues of a system that's grounded in what we know as value-based care? 2, how can we make sure that people, real people and patients, understand that the best elements of the care that they receive or desire lives in the value-based care framework? And 3, how can we make sure that policymakers and stakeholders alike are using the same common language for engaging with real people on this issue? So we approached this sequentially, first to understand people's current healthcare experiences, what they like, what isn't working, and what their overall experience is like. We then wanted to know about the ideal experience they want to have, building on, of course, what we've heard from in our previous research. And finally, we introduced a value-based care approach without actually using the term value-based care, and tried to understand the attitudes and perceptions around that. So how do we go about achieving these research objectives? We used a 3-phase mixed method approach using focus groups and national survey and an online mixed method platform called Remesh. We started with 2 focus groups of about 6 people, one that included a group of people that have generally had good healthcare experiences, and another group that had mostly negative healthcare experiences. There was a range of incomes, education levels, race, ethnicities, and partisanship across both groups, and included people from all census regions. And so the purpose of these focus groups was to understand the current experiences of seeking and receiving healthcare and get some initial reactions to the value-based care approach. We then used some of the findings from those conversations to inform the national poll. We had a nationally representative sample of 1,000 people where we quantified what people liked about the current fee-for-service system, their reactions to a different approach, what we know as value-based care, and the message about this approach that resonated the most. We then transitioned to an online mixed method platform called Remesh with a sample of 100 people across the country to examine those messages a little bit deeper. So why don't we get into what we found? So what you'll see now is a high-level summary of what we wanted to know, the questions we asked to get there, and what we found. And so the takeaway from this table, if you don't make it any further in this webinar, is that people are satisfied with their insurance essentially and prioritize quality care. They do want target improvements to make things better, like better care coordination and being treated as a whole person. And people support the concept of value-based care, although not described in those terms, and believe it should result in a more personalized care, but show some skepticism around cost and time. We'll get in that too a little bit later. So why don't we go a little deeper? Essentially, people are satisfied with the quality of care they receive. However, that doesn't mean they don't want change. People desire targeted improvements to the system. Respondents have a consistent set of criticisms related to their current experiences getting care, which they associate with the fee-for-service approach. This includes having a more human approach where they feel like their providers listened to them, cared about them as a person, and got to the root cause of their problems without feeling rushed. So when we ask people if they would sum up their experience getting healthcare in 1 or 2 words, some respondents will describe something along the lines of assembly line, or as one person said, a school cafeteria, equating it to providers that are quickly dishing out a scoop of healthcare before sending them down the line and moving on to the next patient. So you can see a quote here from one of our low-income participants that has had mostly negative experiences, and this is how he equated the experience from the lunchroom cafeteria to his experience with the current healthcare system. So when we asked about what was working well in their healthcare experiences, people gave high marks to their providers for verbal interactions, such as talking in a way that they can understand, where you can see 92% rated this as good, and listening to their concerns and asking follow-up questions. I will also make a note that from our previous research, when we reference patients being satisfied, that there's a low bar for what satisfied means, and it doesn't mean that people don't require more improvements in the system. It means that they spend so much time hacking the system to get the care that they want. It sets a lower bar and definitely has more room for more targeted fixes, as we will get into a little bit later. So we know that quality matters, but what can we say about people's current care experiences and linking that back to components of a value-based system? This naturally took us to discussing the merits and limitations of the fee-for-service system. Whereas our earlier slides showed us that people are satisfied with the care they receive, there still remains a desire for some targeted improvements, as I mentioned. People were initially divided on how well the fee-for-service approach worked, with about 51% saying that it's not working well, and associated that with a consistent set of criticisms with this approach. And as a matter of fact, in our Remesh session, we saw that just 35% actually believe that the current fee-for-service approach was delivering high quality care. So there was a longer runway and a higher benchmark for that. But people quickly made the connection between the fee-for-service approach and those criticisms of the system. For example, one participant said, from making appointments to dealing with the paperwork and even just waiting in the doctor's office, you need to be patient, no pun intended. And another participant said, you talk to one doctor and they talk about one thing, you go to a different doctor, totally different symptom, they're prescribing medicine that doesn't even work together. And one medicine makes you sick because you took the other. That's what it is, fragmented. So what's our takeaway so far? Well, it's that people want a more human experience when they're receiving care. and shared some of the following examples. The current fee-for-service system is fragmented with little coordination taking place between providers and resulting in people to have to rehash their latest challenges to each provider, sometimes getting conflicting advice. People spend too much time waiting versus with their doctors. Participants wait too long to get an appointment, then too long in the waiting room only to feel rushed and spend little time with the doctor once they get with them. And as a result of feeling rushed, some feel that ultimately they spend more time in the system because they aren't able to address all their issues in one appointment and ending up having to make another one. That coupled with an over-reliance on prescription drugs and them seeing that as the easiest path to address the health challenges. And participants describe how providers often miss the whole picture of what's going on in their lives and how solutions other than traditional medical treatments and medication can actually improve their health. And finally, they feel like people with money are prioritized in getting appointments and care over people that are lower income or are not as well off. So when talking about what they want their healthcare experience to be and what they actually want, participants emphasize increased quality, which they describe as when their own provider genuinely cares, treats patients as humans rather than a series of symptoms, listens attentively, and actually offers solutions that address the root cause of their problems rather than relying on medication. And so a better system isn't just one where they actually get to see the doctor faster, but one where they actually feel like they can get all of their issues addressed in a timely manner in the time that they need. So that's what we heard about the current system and where people want to go. Now let's talk about what happened when we described this new approach, also known as value-based care, that prioritizes what so many were asking for related to increased quality of care. So this is the verbatim language we used in the national survey for people to respond to. And it says, some people have proposed changing the current fee-for-service approach to one that could pay doctors and providers for improving overall health, delivering higher quality care, and helping coordinate their patients' care. So when we ask people in response to that prompt, how well do you think an approach that pays providers for improving overall health, delivering high quality care, and helping coordinate patients' care? This is what we found. When they were forced to choose between us and the fee-for-service and the current system, providers being paid based on results is preferred by a 4-to-1 margin over the fee-for-service. And you can tell that from the blue bars. The new system versus the current system in red bars. And what we saw was this was true across party identification, insurance type, ethnicity, age, education, and even geography. And we didn't see these results just in the survey, but all across all three research tools. We saw high levels of support in focus groups. As you can see, 64% in the national survey thought this would work well. And in our remesh sessions, we saw that 89% of participants supported this approach. Almost immediately, people saw an opportunity for more personalized care. However, respondents also quickly perceived this to be a large overhaul to the system, which previous research has told us that people do not want. And they certainly equated all of this with an increased cost. Now, what we did see in our remesh findings was that people were still able to make the connection with this new approach and the care that they want to be receiving. And they were also aware that the current payment system prevented their providers to be able to deliver this type of care. So essentially, they liked the idea of incentivizing the providers to give them the care that prioritizes quality over quantity. But people, of course, also had their reasons to be skeptical. They worry that it could cost more if doctors were seeing fewer patients. They worried that a move away from fee-for-service might encourage providers to ignore certain or more complex problems to favor ones that could actually be fixed. And they were also worried about the wait times since they would be spending more time with patients. So from all of our methodologies on message testing on value-based care, we were able to assess 4 main recommendations for how to talk about this newer approach with everyday people. The first is to state the need. Our research has shown that people want the quality care they deserve, regardless of their identity or where they live, that meets their unique needs that the current fee-for-service system does not do, and prioritizes the patient for overall better quality outcomes. Number 2, describe how it works. Rather than paying for care based on the number of visits, tests, and procedures, this approach allows people to spend more time with their providers so that they can get to know their patients and develop more personalized approaches to addressing their full set of unique concerns in fewer visits. The third, describe potential benefits. This approach also encourages providers to coordinate with one another while taking a broader view of all of the factors that may be impacting a person's health, rather than jumping too quickly to the next patient or to prescribe drugs in order to potentially unnecessary procedures that drive up costs. 4, inoculate against potential concerns. This approach is targeted and a straightforward fix that puts quality over quantity, eliminating the greed in our healthcare system that results in patients being treated as a series of symptoms rather than a whole person, while helping identify and manage health concerns that could become very expensive if ignored. So now I'd like to take a couple of minutes to walk through some of the cautions and considerations that we also recognize based on our findings. The first was that the term value-based care is essentially subjective and encourages misinterpretations and misunderstandings of what is trying to be achieved. Some research participants connected with the term because they wanted to feel more valued by their provider, but a majority associated with it being cheap, low quality, a cost-saving measure like value-based brands in the supermarket. In the survey, actually, respondents approve of quality-focused care or a patient-first care, 89 or 86% respectively, while the term value-based care actually got 59% approval, with less of half of the intensity of other terms. In our remesh session, one participant commented that value-based care made them think of cheap, low-quality service. And actually 75% of those participants agreed with that sentiment. The second caution is that there's a perception that the approach would result in increased cost. In our survey, we saw that 46% thought that the cost would increase compared to 14% that actually saw that the cost would decrease. And one remesh participant commented, "I feared being more expensive because the doctors couldn't see as many patients." And actually 69% of our remesh participants agreed with that. So we know from past research that people's top goal for the healthcare system is to reduce costs. Solutions that people think would increase costs would likely face significant challenges in building public support or uptake. So when we tested that message centered on cost control, participants liked the idea, but they were skeptical that this approach would actually live up to its promise. So we recommend integrating real-world numbers about potential cost savings of this approach into messaging as it becomes available. So for now, we actually recommend emphasizing the cost savings that could result from treating health concerns that would become expensive if ignored, while avoiding the cost of uncoordinated care and unnecessary procedures. The third caution is, while we see high levels of interest in moving to this approach, people are skeptical about how it will work in practice. And they actually call out several drawbacks, including the sense that shifting approaches would be an overhaul of the current system. We saw in our survey that 52% considered this to be a large overhaul. And we know from past research that a majority of the people prefer targeted fixes that won't disrupt their existing care and providers. The solutions that feel like an overhaul actually have less overall support. They also fear that it would make it harder for people to see their providers and get care. Those with less firm initial opinions on this approach were much more concerned about it being harder to see their doctor. And we heard from one rematch participant say, doctors wouldn't have enough time for everyone. A lot of resources would be spent on people with small problems. And we saw about 63% of people agree with that. We also heard that doctors would be even more overbooked, which would make longer wait times for appointments. And 63% of people agreed with that too. So a concern that this approach would disproportionately advantage those with more serious or diagnosis or chronic conditions, as their understanding leads them to believe that providers would actually be disincentivized from treating these types of patients. And we heard from one focus group participant say, I feel like it would help people with curable diseases the most, because if doctors are getting paid for results, they're probably going to put a little bit more effort towards something they can cure rather than something that they could just treat. And then one rematch participant said, reduced profit incentive could lead to apathy or ignoring certain types of problems. And we saw 64% of people agree with that. So similar concerns about cost increases that we mentioned above adds to the skepticism. So we recommend integrating and or testing the real world impact of these items to alleviate these concerns. So the fourth caution is that we want people want to have every treatment available to them if they ever need it. Concepts that highlighted the perks of avoiding potential unnecessary tests when we tested it in our survey actually backfired. And so you can see a couple of quotes here. More tests could be useful. I mean, at the end of the day, they're investigating your condition. Sometimes you need it. And another participant said, I'm not sure how it would work. What is the end result that they're being paid for? I mean, obviously, if there's an illness that is curable, but say there's an illness that is not curable and they're treating you, but like, don't you want to be cured like Alzheimer's or something? How do they succeed at something like that and still get paid? So the fifth and final consideration is shifting away from the fee-for-service approach requires complex technical changes to the payment system, provider behavior, and health insurance procedures. And as a result, there is likely to be a tendency to move quickly into those details, which our findings show could create significant challenges for building public support. People respond positively to the new approach when we focus on the patient experience. We tested a variety of topics related to providers, including their motives to enter the field and whether they should be incentivized or held accountable for providing care. It has good outcomes. And we heard a mix of responses and highly recommend keeping the public messaging focused on the patient experience. Some of the findings related to providers actually included, I think most doctors come from wanting to help people in the beginning, but most lose that personal care over time and care about the money in the end. And we see 60% agree with that. And participants were split on the need for accountability, which they organically introduced in the focus groups versus giving providers financial rewards or incentives to provide high quality care. So they said the system must get away from money and instill one that focuses on outcomes. There is no accountability. Doctors can get away with whatever they want. And as long as they think it benefits the patient, yeah, it's very risky. So here's a summary table of the messages that resonate and gives nod to the considerations and cautions we just outlined. This is a good tool to keep in handy for when you hear some of the common terms related to value-based care come up. This is one that you can kind of reference as a say this, not that. And when you look at the rationale, that encompasses both what people have wanted from the system and the skepticism that also needs to be addressed within this approach. Next. So as I get ready to close, here's a recap and summary of items to keep in mind when talking about a quality over quantity approach. First, use simple language. Participants throughout our research have consistently defaulted to simple phrasing and familiar terms. A lot of existing language describing the approach is overly complex. And if the goal is ultimately to increase implementation and uptake of this approach, it's important that even public officials and policymakers use language that are relatable to people. Stay focused on how the approach will improve experiences getting care, with an emphasis on increasing high quality care. The opportunity to increase quality has been welcomed by research participants and was a top selling argument actually for shifting away from the fee-for-service approach. Get ahead of concerns that people express. And finally, don't use the term value-based care. Well, Kristen, that's all I have for now. I can turn it back over to you.
Thanks very much, Venice. And now with this work completed, here's a look at what is next for us. We've consolidated these findings into a toolkit of easy to use resources, which are available on our website that we hope will help you use messaging that resonates with people. We'll also continue to share what we've learned with policymakers and interested audiences like you. And finally, we plan to conduct further research as needed to deepen our understanding even further. Thank you so much for listening in to today's briefing. We hope that you found it informative and thought-provoking. The United States of Care team will continue to pioneer innovative research on this and many other issues, and we look forward to keeping you informed.